So if you're using something orally, you're not skipping first pass. In fact, you're getting a significant amount of potentially additional enzymatic activity occurring where minoxidil is converting to minoxidil sulfate. When you apply it topically though, what's up guys, Derek, moreplacemoredates.com. Today we're going to be talking about oral minoxidil versus topical minoxidil. Is there any application for oral that makes sense? If you've looked into it at all, you've probably seen that oral is far more efficacious than topical. Now, this isn't accounting for the fact that the liver has a significant amount of sulfotransferase enzyme activity, which is problematic for those who are minoxidil non-responders. If you've seen my video on how to double your minoxidil results, realistically, it's probably like 3 to 4 times your minoxidil results if you're a non-responder. The addition of tretinoin to topical formulations as well as microneedling on top of that can, 3 to 4x your minoxidil results, in addition to change a non-responder with a low amount of sulfotransferase activity to a actual responder. But when you take it orally, there is additional activity that takes place at the liver itself that converts the minoxidil to the minoxidil sulfate above and beyond what you get just with the outer root sheath of the hair follicle. You get this additional systemic exposure that you may not get as complete of an amount of should you use it topically. So that, leaves the question, should you not, like, it's almost like finasteride. If it's going to go systemic, should you not just use a, lower dose of oral and just have it work, make sure it's getting in there the amount it needs to get in there, especially when it comes to something that actually requires enzymatic conversion at the liver to maximize the amount of the prodrug converting to minoxidil sulfate? Should you not just take it orally at a lower dose to get there? That remains to be seen. That's sort of what we're going to be delving into today. So, in theory, the kind of step-by-step approach I would take personally before looking at oral minoxidil at all would be, first of all, like, I guess you could do assess your SNPs through your genome to see if you have high sulfotransferase activity or not, or you can do that, test that's going to be being released. Or I think the main kind of like starting newbie approach would be microneedling once a week at 1.5 millimeters and not applying any topicals on that day. And the other 6 days of the week, you apply your 5% minoxidil 1 to 2 times per day. Ideally, some people might argue 1 time a day is sufficient. It may be, but the standard protocol is 2 times a day, morning and night, 5% minoxidil. Sunday or whatever day you want to do it, you microneedle with 1.5 millimeters, which in itself may enhance sulfotransferase, the enzymatic process itself. Now, the other thing that poses an interesting question is the fact that the molecular weight of minoxidil is pretty low. It's only 209.251 Daltons. So obviously the 500 Dalton rule isn't set in stone, but at the end of the day, what we do know, finasteride has a 372.5 Dalton molecular weight, and we can see how easily that goes systemic, like crushing serum DHT levels with the exact same dose that it would take orally to do the same thing. And that's 160 Daltons higher than what minoxidil is. So minoxidil is only 209. So keep in mind, when you're applying 5% minoxidil twice a day, a lot of people just think in their head the percentage, but they're not actually thinking in milligram amounts. You're actually applying 100 milligrams of minoxidil to your head every single day with a topical application mixed in a vehicle with a 209 Dalton molecular weight. So trying to, expecting that to not go systemically, it's going incredibly systemic to the point where I would probably theorize that using a low dose of oral minoxidil is probably not a lot different than using the topical. That's my own speculation though. And obviously take that with a grain of salt. Just the fact that finasteride though, we've seen how systemic it goes with an almost 400 Dalton molecular weight. Just minoxidil, it's, I don't think you could expect less, that's for sure. So you're getting a decent chunk of that 100 milligrams. Now, when we actually look at the dosages for oral minoxidil for hypertension, for example, we're looking at like 10 to 40 milligrams a day for hypertension. That's not for male pattern baldness though. For male pattern baldness, it's like 2.5 to 5 milligrams is pretty typical. And women supposedly can get away with less, you know, which logically makes sense. They have less, you know, propensity to androgenic alopecia. Why would they need as much as a guy? And they also just weigh a lot less. You know, obvious things. Now, so you'd be taking a dose that's like so many, like 10, 20, 30, 40 times less than the dose you were applying topically. Well, actually you're taking like 50 to 100 times less than you're taking topically, but for a dose for hypertension, you're taking 10, 20, 30, 40 times less orally than you would for hypertension. So can you really expect a significantly heightened side effect profile, or would you just get kind of like the same side effect profile and potentially more of that conversion at the liver from minoxidil to minoxidil sulfate, hence potentiating the drug and making it even more potent than using it in a topical formulation? There's a couple studies I want to bring up that kind of elucidate the results of low dose oral minoxidil just to shed some light on this. So this study is called Oral Minoxidil, Possible New Therapy for Androgenetic Alopecia. And this was using 2.5 or 5 milligrams of daily oral minoxidil for greater than equal to 6 months. Overall, clinical improvement was noted in 90.2% of patients, and marked improvement of at least 1 grade on the Norwood-Hamilton scale was seen in 26.8% of study subjects. 9.8% of patients remained stable, and none worsened with respect to their hair loss. The adverse effects of hypertrichosis, lower limb edema, and shedding were noted in 24.3%, 4.8%, and 2.4% of patients, respectively. All of these cases were documented to be mild and well tolerated. Another study of 30 male patients treated with 5 milligrams of daily oral minoxidil for 6 months demonstrated similar results, with 100% of patients showing clinical improvement and 43% showing marked improvement. However, rates of adverse effects were higher, as 93% developed hypertrichosis, 10% developed edema, and 10% developed electrocardiogram abnormalities, which is a obvious concern when you're using something like minoxidil, which is a potent potassium channel opener. Lower dosages of oral minoxidil have also shown preliminary success for female androgenetic alopecia patients. In a study of 16 female patients treated with 1.25 milligrams of daily oral minoxidil, increased hair growth was seen in 28% of patients, and shedding decreased in an additional 33% of study subjects. Hypertrichosis was reported in 39% of patients, yet no participants discontinued their therapy. In conclusion, oral minoxidil may be considered in male androgenetic alopecia patients in whom standard treatment options failed or were contraindicated. Lower dosages may be considered in female patients. It may also benefit clinicians to know that the drug is metabolized by the liver and excreted by the kidneys. Randomized clinical trials are necessary to further evaluate the efficacy of oral minoxidil alone or in combination with other therapies to treat androgenetic alopecia. So that is one study of note. In addition to that, the other study, called Very Low Dose Oral Minoxidil on Male Androgenetic Alopecia, a study with quantitative trichoscopic documentation. In this, they did a retrospective review of medical records from patients with male androgenetic alopecia using 0.25 milligrams per day, 0.25 of oral minoxidil. Patients included had at least 24 weeks of follow-up and records of clinical and trichoscopic images. Patients with recent, less than 6 months or concomitant use of other therapies for androgenetic alopecia were not included. For evaluation of treatment response analysis, pre-treatment and post-treatment, 24 weeks, trichoscopic images from the frontal, scalp, midline, and vertex were carried out by using Photo Finder Tricholab Snap software. Let's see. So the sample included 25 patients with a mean age of 36.7 years. 40% had mild androgenetic alopecia. 60% had severe. Improvement or stabilization after 24 weeks was observed in a percentage of individual patients for all parameters analyzed. Frontal scalp, new terminal hairs, 48%. New hairs, 52%. Density of terminal hair, 40%. Total hair density, 60%. Vertex, new terminal hairs, 44%. New hairs, 40%. Density of terminal hairs 44%, total hair density 40%. Side effects: petal edema in 1, only 4%. Hair shedding in 4, 16%, which is, that's usually one of the main things you see with topical use is a ridiculous shed, as you probably already know. Body hypertrichosis in 5, 20%. Interestingly, 13 patients, 52%, reported perception of increased hair density in the beard. There was no difference in mean arterial pressure and no reports of fainting or dizziness. No patient discontinued treatment. The small sample size and high percentage of patients with advanced androgenetic alopecia in our study are possible explanations for the lack of statistical significance. For those reasons, we cannot exclude a type 2 error. As shown with topical administration, oral minoxidil might have lower efficacy in advanced androgenetic alopecia. Additionally, we speculate that higher dosages of oral minoxidil might be necessary to produce significant effects in men. Different methods for assessing treatment response prevent comparison with our results. Despite the higher dosage, their profile of adverse effects was similar to ours. So that is the second study of note. The third one, the last one, is effectiveness and safety of low-dose oral minoxidil in male androgenetic alopecia. So in this one, they retrospectively reviewed male patients who had, let's see, 2.5 or 5 milligrams daily was given for a minimum of 6 months. This dosage was based on a previous report. Therapeutic response was assessed by comparison of pre-treatments, blah, blah, blah. Total of 41 men, mean age 33.3 years, were included. They received oral minoxidil at a dose of 2.5 milligrams or 5 milligrams. In all, 25 patients had previously undergone other therapies for a mean of 18 months. 18 patients used oral dutasteride. 9 patients used dutasteride mesotherapy, which is like injecting dutasteride into your scalp, or microneedling it in, I guess. 3 patients tried oral finasteride, 2 patients tried topical minoxidil, 1 patient tried topical finasteride. A total of 16 patients received oral minoxidil as monotherapy. That means with nothing else, no anti-androgens, no 5-alpha reductase inhibitors, nothing. Clinical improvement was observed in 37 patients, which is 90.2%, with 11 of them, 26.8%, presenting a marked improvement. 4 patients showed stabilization, none of them worsened. All those in the subgroup of 16 patients receiving oral minoxidil as monotherapy presented clinical improvement, with 6 patients showing marked improvement. Adverse effects were detected in 12 patients, which is 29.3% of them. Hypertrichosis in 10 patients, 24.3%. Lower limb edema in 2 of them, 4.8%, and shedding in 1 of them, 2.4%. All of the adverse effects were mild and well tolerated. Only 1 patient discontinued the treatment because of petal edema. These adverse effects appeared with the dose of 5 milligrams daily, except in 2 patients with slight hypertrichosis and 1 patient with shedding at 2.5 milligrams daily. Oral minoxidil 0.25 milligrams to 1.25 milligrams daily has been used for the treatment of female androgenetic alopecia, traction alopecia, blah, 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 showing improvement in 61 to 86% of patients and a good safety profile. So obviously that percentage is a lot higher than topical. If you remember, the topical percentage of improvement was like 40 to 50% at best. So more people using oral are getting a response out of it. And this is likely, I'll tell you after. The study's retrospective design and low number of patients or limitations. In conclusion, oral minoxidil at 5 milligrams daily was effective and presented an acceptable safety profile in our cohort of male patients with male androgenetic alopecia. The optimum dose needs to be delineated in future controlled studies. So what I get out of that, which is something that should be considered, is the fact that the liver has a lot of sulfotransferase enzyme activity, which converts minoxidil to minoxidil sulfate, which is actually what we want. And you're getting more drug into circulation via this oral ingestion just by the sheer enzymatic processes occurring during the metabolism process. So the thing that's kind of presents an interesting scenario to me is the fact that when you take something orally versus topically, what happens when you inject something or you use it topically? You use it to, you can leverage that to skip something called first pass metabolism, where your body breaks down the drug and has a metabolism process that occurs in the liver. So if you're using something orally, you're not skipping first pass. In fact, you're getting a significant amount of potentially additional enzymatic activity occurring where minoxidil is converting to minoxidil sulfate. When you apply it topically though, you're skipping first pass, just like if you injected it. This is where, you know, the injectable SARMs experiment kind of reared its ugly head. And when we skipped first pass, I actually likely lost a lot of the tissue selective metabolites that come from using oral LGD. And I just mainlined straight LGD, and whatever the result of that was, whatever metabolites weren't created, it was a lot more androgenic than it is when you take it orally for a, you know, proportional dose. So when you use a proportional dose of oral minoxidil, are you really getting any additional side effects above and beyond the 100 milligrams you're topically applying, but you're skipping that first pass when you apply it topically, where you may actually squeeze out a significantly higher amount of minoxidil to minoxidil sulfate conversion? So this makes it interesting to me as somebody who's trying to maximize outcomes with the greatest limitation of side effects. Would it not make more sense to potentially just use 1-2 milligrams of oral minoxidil instead of applying 100 milligrams daily? So not only could you get potentially more conversion to minoxidil sulfate, but you're potentially getting a lower exposure to the overall, like, I guess at the end of the day, you could be getting the same drug amount systemically, but in addition to that, you're not having to apply the shit twice a day, which is a huge hassle to begin with. Like, at the end of the day, we're trying to get this, you're trying to get into the system, but keep it localized at the same time, which is an interesting proposition when you're using something that's almost 200 Daltons in molecular weight. So to me, this would be a completely different conversation if it wasn't the fact that during the first pass, and if you don't know what that is, just go Google it. Basically, it's where the drug metabolism, whereby a concentration of a drug, specifically when administered orally, is greatly reduced before it reaches the systemic circulation. But what you need to know about that, like I said, the fraction of drug lost during the process of absorption, which is generally related to the liver and gut wall. So the topical application, even if you circumvent this can be advantageous with certain drugs. Like, for example, metformin is something that me and my clinic are theorizing we may be able to leverage topically to avoid some of the gut distress that happens. That's a bit of a different topic, but I'm just saying sometimes the first pass is necessary to actually yield the metabolites that you're trying to get out of the drug, or maxing out the conversion process. The same thing happened with SARMs that I saw. Anytime anyone injected this shit, they had a super androgenic outcome that just made no sense compared to what the stuff does orally. But then when they use it orally, you know, all the properties that you want to get out of it, the tissue selectivity, were all maintained. So with minoxidil, are we just using a less efficacious method of application simply for the fact that it's over the counter rather than a prescription drug that you have to ingest? I don't really know, to be honest, and this is something I'm going to be delving into further myself in the future, because despite the fact that 5 milligrams seems to not be like super well tolerated, I think there is a lot of promise in using something potentially like, you know, 1-2 milligrams a day. And it might be significantly better. Like, again though, as far as just safety and tolerability wise and knowing what to expect, as well as having access, because obviously getting topical minoxidil is like the gold standard versus getting a prescription for oral minoxidil, which is something I'm going to be exploring through my clinic as well, that we'll see in the future. Obviously, you know, right now there's nothing set in stone, so, you know, just keep it in the back of your head, but we'll see what happens with that, if there's some way to offer it moving forward. But I'm pretty sure it's pretty easy to access if you did want to experiment with it. Not that I'm saying to experiment with it, but I'm just saying I'm pretty sure you can get Lonatin like super cheap online. Yeah, like at the end of the day, the goal seems to be maxing out how much minoxidil sulfate we can get. So obviously the first approach for most people that makes the most sense is topical plus microneedling. I think the step above and beyond that is probably compounding your minoxidil with tretinoin to enhance sulfotransferase enzyme activity in the scalp locally. Above and beyond that, if you have not achieved satisfactory results, that's when I'd start looking at some of this clinical data and starting to evaluate, am I really getting more bang for my buck by increasing my minoxidil percentages topically to, you know, 10, 15% or whatever, if I haven't got the results I want? Or would I maybe be better off exploring some of the oral minoxidil route? I'm not saying to do it. I'm just saying the research is warranted to delve into this further, because the actual activity in the liver itself interests me in how much proportional minoxidil sulfate is being created relative to using it topically and just trying to max out enzymatic conversion at a topical level. You know what I'm saying? So we'll see how this goes in the future, but I think this is something that we are going to have elucidated to us more as more people start to come out of the woodwork and give their experiences with it, as well as talk about more studies come out assessing it as well. So these are all very new, to be honest, like these low dose minoxidil studies. So we're going to see moving forward, but anecdotally, it seems like, you know, 1 to 2 milligrams a day seems pretty efficacious and pretty well tolerated. And we're going to see what happens moving forward. I would be highly cautious though of doing this, and obviously be under doctor's supervision, have a prescription, blah, 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 because this is indeed a cardiovascular intensive medication that can have some deleterious outcomes if you're not careful about it. So do not take this video as me saying, go pop minoxidil tablets. This is me saying this warrants further research and it's interesting. And that's pretty much what you can take away from it. So let me know what you guys think in the comments down below. Do any of you have experience with low dose oral minoxidil? If so, please comment down below. How did it compare to topical, proportionally dosage wise? You know, most people are using 50 to 100 milligrams of topical minoxidil per day, and they don't really realize how much actual systemic exposure they're getting using it topically to begin with. Have you tried, you know, the 2 milliliters per day topical and then compared it to, you know, like 1 to 2.5 milligrams of oral per day? If so, what was the difference in your side effect profile? If any, were the side effects worse? Were they better? Were your outcomes and hair growth better or worse? Any and all experiences are going to be appreciated by the community down below, as well as myself, because obviously this is interesting for me too. So please drop a comment if you have an experience that is relevant to this, as well as any other additional information you may have that would benefit the community at large. Yeah, if you can like, that helps the algorithm too, as well as your comments in general. Those help and those are much appreciated. Follow me on Instagram at moreplates_more_dates, Facebook, Snapchat, BitChute, Twitter, TikTok, Apple Podcasts. If you want to support my channel, you can check out anything I'm associated with in the video description below. If you want to get hooked up with minoxidil compounded with tretinoin, topical finasteride, latanoprost, anything that may have some clinical efficacy in a hair loss prevention context, I compel you to check out. I guess compel isn't the right word. I have been corrected before in the past. When I've said that in previous videos, I encourage you to check out my HRT clinic. And we have a decent variety of hair loss formulations that I feel are, you know, it's pretty bare bones to start, but the heavy hitters are all there. And there's topical formulations available that are going to, you know, be difficult to make at home. Well, not for everyone, obviously. If you can do it at home, it's going to be more cost effective, but some people want a legitimate prescription from a compounding pharmacy, pharma grade stuff they can travel with, blah, blah, blah. Anyways, if you're interested in that, you can check it out. The link is in the description below. Anything else I'm associated with, video description below as well. Thank you guys for watching. Talk to you soon.